My name is Dr. Ken Alletne, a sports medicine and joint reconstruction surgeon. And we have a series of videos that we're going to discuss some of the more common things that we see here in my orthopedic surgery and sports medicine practice. By way of background, I am a board-certified orthopedic surgeon. My training has occurred at many places around the country, including Williams College, Medical School at Wake Forest University, Howard University Hospital for residency, Yale University for my sports medicine fellowship, and then a research fellowship at Harvard MIT in Cambridge. The majority of my practice are problems of the knee and shoulder, and our practice here at Eastern Orthopedics and Sports Medicine ranges from school-age kids to active seniors, professional athletes, collegiate athletes, and Olympic athletes. So we have a pretty diverse practice. What we'd like to do today is discuss a series of the more common things that we see in hopes that it will help to direct our patients in their care to ask the appropriate questions of their doctor and to make sure that they have good information in regards to their orthopedic concerns. Arthritis of the knee is a problem affecting millions of patients in the United States. Arthritis, the most common type, being osteoarthritis, can be seen in patients in their late 20s and early 30s, all the way to the later years in life. The key to that arthritis is how do we allow our patients to be active, or at least as active as they would like, and live with their arthritis in a way that doesn't cause them a great deal of pain and dysfunction. Diagnosis of arthritis is done with the orthopedic surgeon after a good history and physical, and often by utilizing x-rays or other forms of imaging such as a MRI or magnetic resonance imaging. Treatment for arthritis is a myriad of things. We generally say in our practice that there's no one thing that's going to help the pain of your arthritis, but it's a combination of many things that come together to help improve your pain and any lack of function or dysfunction that you may be having. For instance, some of the more common treatments once arthritis is diagnosed are anti-inflammatory medications, if they can be taken safely, such as Advil, Motrin, or prescription medications, which should be done in consultation with your primary care physician, knowing your medical history. Physical therapy. Weight loss. In the United States, we know that gaining weight and obesity is a very, very common problem. For every 1 pound you put on, your knee can see 3 to 4 pounds. So for every pound off, you can actually have multiple pounds off of your knee. Good shoe wear, meaning staying in well-cushioned shoes that help to absorb some of the force that occurs when we walk, that multiplies or that causes that 3 to 4 times per body weight through the knee. As well as utilizing things like ice and appropriate activity modification to help with your symptoms. Your physician may try things like cortisone injections inside the knee and other forms of injections that are utilized to help lubricate the knee, make the knee move more smoothly, and cause less pain. Arthritis affects the smooth gliding portion of the joint, what's called the articular cartilage, here and down in here. These are the areas that are often and primarily associated with arthritis and cause the pain. It can start out with just a little bit of inflammation and swelling in this cartilage, all the way down to complete wearing away of the cartilage, exposing bone that's normally covered by cartilage. Exposure of that bone, or increased pressure on that bone with the wearing away and thinning of the cartilage, is part of the pain process in arthritis. Ultimately, for patients who have not had success with medication, physical therapy, bracing, controlling of their weight, strengthening and stabilizing of the knee, which are the hallmarks of a treatment program for arthritis, and for the vast majority of patients in the United States, thankfully, helps them to be able to live with their arthritis and maintain very active lifestyles. For those patients who that does not work, then there are operative options or surgical options. In 2012, for true arthritis, those options generally fall into two camps. The partial knee replacement, which is a replacement of just a portion of the knee that's diseased. Most commonly, for most patients, that will be the inside portion of the knee or the medial compartment of the knee. The diseased cartilage there is resurfaced during this procedure, which can be done through a relatively small incision, 5 to 6 inches, and the remainder of the knee is not touched. Those patients get up and walk immediately, and can lead very, very active lifestyles. In my practice, those patients are playing tennis, they're hiking, they're biking, they can be involved in very aggressive walking, rowing, and many, many sports, with just resurfacing that one area inside the knee. For patients where the arthritis is more pervasive or involves other areas in the knee, which would mean the outside of the knee or the lateral compartment and or the patellofemoral compartment or the area behind the kneecap, partial knee replacement would not be a solution, or at least not a predictably good one. In those patients, total knee arthroplasty or the knee replacement is required. In the knee replacement, we are generally resurfacing or recovering the knee, the diseased portions of the knee, with the implants, which are made generally of metal and plastic. We generally quote to patients anywhere between 10 to 20 years, 15 to 20 years of longevity of that procedure. That's done in the hospital. Patients generally will stay for at least a couple days, although there are some centers where patients are being sent home on the same day, require physical therapy in the hospital, and then will either go home or to a rehab institute for an inpatient rehabilitation to begin their rehab immediately. Those patients also can lead very, very active lives. My patients with total knee are very active in doing diving, scuba diving, hiking, biking, rowing, canoeing, obviously walking, and workouts in the gym, allowing them to still be able to maintain a very active lifestyle. I often tell them it's much easier for me to fix your knee than for the heart surgeon to fix your heart because you're not active, which is another reason that drives patients to have these procedures done so they can restore their active lifestyle. Most patients are up and walking pretty well at 2 to 3 weeks, meaning getting about fairly well. In my practice, we like to get our patients up either the same day or the next day to begin walking with a physical therapist immediately in the hospital and to continue that as an outpatient. Walking is a very, very good therapy for the patient in addition to physical therapy, so we encourage walking in active ranges of motion. The total knee procedure is a predictably good one, but really relies upon the patient being motivated to do the exercises on their own, at home, or in the gym. We can do a great surgery in the operating room, and the physical therapists are great partners to ours for the hour or hour and a half that you may spend with them 2 or 3 times a week. But the real work for a total knee needs to be done on your own, at home, moving that knee and walking to get your range of motion. When patients regain their range of motion, they often restore a lifestyle that they didn't know they could have and often say and wonder why they waited to have the procedure. A new innovation in total knee arthroplasty are what's called custom knee implants and custom knee molds. By this, we mean various knee replacement companies now will actually create a knee implant just for you based on your knee, or knee cutting guides that are meant to ease and make the procedure more accurate just for your knee. I happen to utilize the Zimmer Total Knee and a system called PSI. By that, pictures are taken of your knee with MRI. Those pictures are then sent to the company. The company takes that digital image and creates custom guides that are just meant to fit your knee. That means at the time of surgery, we're able to make our cuts more accurately, the cuts in the bone that we need to make to resurface. We are able to do that without drilling into the bone, which means less pain and less blood loss. And I believe we're going to see for many of these patients a quicker rehab. But certainly, should you have more questions, please don't hesitate to visit www.zimmer.com or our website, www.eosm.net. Thank you.